was the food journey. Oxygen to the canary. We've done that. The canary is alive and well. So it's no longer about saying to Tommy, like, you're okay, we'll see in 6 months. We need to change this.
Hola amigos de la R.M.P, vamos a empezar a transmitir el evento del Congreso. Está hablando una doctora de Estados Unidos. We talk about that is for English today. And we will start the presentation. It is only an advance in my presentation. It will be now when they finish this doctor. When the doctor finish, I will start the presentation. I hope you enjoy this part of the meeting. And the presentation of today in our channel is regarding the craniofacial dysfunction in connection with the postural system. Enjoy the presentation. I will leave with the Congress and stay there.
It's important to incorporate data from the neuron into the electronic health records. And this again is a prototype. I'm still working on it, and I'm planning on taking the course in January with artificial intelligence, because I know that with AI, I can figure out how to incorporate this important set of data into the overall electronic health records. And because I know that physicians are extremely busy, literally overburdened with information, unfortunately, that's been brought up with the massive amounts of records they receive every day. I've designed it to be simplified and include flags. So, for instance, all that will show in the EHR for a patient that has no caries detected, no periodontal problems detected, and no concerns, all the physician will see is a green flag. And that will be a cue for the physician to first congratulate the patient on his good oral health and connect oral health with the rest of the body and praise that person for the fact that likely the rest of the body is in very good shape. And then I've introduced a red flag, and this is for the other type of patient who has a yes to caries or a yes to periodontal disease or both. And so therefore there are concerns for the systemic health of that patient. And now the physician, seeing the red flag, can open and can see how serious the caries disease is, or how serious the periodontal disease is, and check what other systemic issues that may be jeopardized by what's happening in the mouth, or by the warning that's happening in the mouth, and see to it that some tests are being done early. For example, A1C, or the glycemic index, or a lipid profile, to start checking before the signs and symptoms of systemic diseases, chronic, non-communicable systemic diseases related to diet manifest themselves. So we have a huge potential there, but this again is just a prototype. And finally, there's another flag that comes in, and this is a yellow flag. And that indicates to the physician that this particular patient has not been seen in the dental office for 12 or more months. And it can prompt different questions from the physician. Why have you not seen a dentist? Has your dentist retired? Can we help you find a dental clinic? If it's an economical problem, then perhaps that clinic, that medical clinic, can help find a clinic for that particular patient. So these are all things that still need to be developed, and they stand to save a lot money to the whole system. So, in other words, teeth are sentinels, and decoding their message can reshape public health. And before I go to the last slide, I'd like to mention that here in the United States, the budget, the expenditure for healthcare is $4.5 trillion. That's enormous. But here's what you need to know, is 90% of that budget goes to the treatment of non-communicable diseases. So imagine if we could, from shifting our perspective from tooth decay to caries, from moving forward into seeing caries as a sentinel health event,
Dr. Pariso, your microphone is muted.
okay.
Now it's good. Okay, now we can hear you.
So where did you lose me?
It was 15 seconds ago. You just started talking.
It was around 90% going to
Okay, thank you. So yes, so 90% of $4.5 trillion goes to the treatment of non-communicable diseases. So that's a lot of money. That's $4.05 trillion. So imagine if the shift that we propose, and I think by now I've proven that caries is indeed a sentinel health event. So if we manage to create that shift and to move forward into seeing caries as a systemic event, a systemic disease, and by doing so, we reduce the incidence of non-communicable diseases by only 1%. In the United States, that will be a savings of $50 to $60 billion a year. So the way I see it, it would be quite reasonable to ask government agencies for a loan of $30 billion to get this process started and see what we can achieve with that. And over the years, I'm convinced that we could see a reduction of well over 1% in non-communicable diseases, and therefore reduce the burden of these diseases on populations around the world. So my next slide is the last one. Oops, it's gone. So in a nutshell, caries is a sentinel health event. I rest my case. Thank you so much.
Thank you very much, Dr. Pariso, for a great presentation and the importance of collaboration and also importance of artificial intelligence in diagnosis and classification, and also the importance of the result of this artificial intelligence to find ways of treatment in different fields of nutrition and so forth. And, that's a very, very important point that you made. And you made it very colorfully based on history and geography. God bless you. Thank you very much.
Thank you. And if anybody has questions for me, I'll be happy to answer them.
Maria, thank you for your presentation. Thank you so much.
Thank you. You're most welcome.
I think our next professor to present is Mariam Margelashvili Malamet. I think, I'd like to make the presentation. First of all, it's an honor for me to make, the presentation of Mariam Margelashvili. She is, first of all, the daughter of my dear colleague, Professor Vladimir Margelashvili, who is the representative of this country, Georgia, within the FDI, the full professor, and it's most important is like my brother. So Dr. Mariam Margashvili is a diplomat of the American Board of Prosthodontics. She holds a Master of Science and a PhD degree in dental materials from the University of Siena, Italy, and Certificate of Specialty in Prosthodontics from Tufts University School of Dental Medicine. Dr. Margashvili Mehmet has published several articles, abstracts, and co-authored many book chapters. She is a fellow of the ACP, Associate Fellow of the GNYAP, and the Academy of Prosthodontics. She serves as an associate professor at Tufts University and works in specialty prosthodontics practice, Boston Prosthodontics. And I am proud of her professional successes of Professor Mariam Margashvili. And without further delay, I would like to invite Professor Mariam to make her presentation.
Hi, everyone. Thank you for a wonderful introduction. Nice to see you all. I'm not sure how to share. Okay, here it is. Give me a minute until I figure out.
If you need the help, we can provide it. Oh, okay, it's working.
All right, I cannot see myself anymore, but I can see my slides. Does everyone see my slides?
Yes. We can see it, and you can also be seen.
Okay, excellent. So, well, again, thank you so much for kind introduction, Bedros, and I'm honored to be here to share some of my thoughts. Today, I'll talk to you about a story of a tooth, from a restoration to this magical solution that prevents our patients from having to wear removable prosthesis. But I'm also going to try to talk to you how soon we'll make the decision to replace the teeth with implants. The way we practice is often defined by the patient category, their demands, and available dental materials. On one hand, we see patients with increased life expectancy, increased number of retained teeth at older age, but because of older age, the patients are on polypharmacy, and we all know that polypharmacy entails significant dental considerations like caries and tooth wear still persist in up to 29% of adult population. Both caries and tooth wear result in loss of tooth structure that needs to be restored. On the other hand, smile has become a sign of social status. Everyone wants to have tooth-colored white restorations, beautiful smiles, high aesthetics, regardless of age. That sets the goals for us. We want to deliver restorations that are biologically friendly, and we want the restorations that will survive without fracture, the one that will maintain occlusal schemes, but at the same time provide aesthetics. The question is, are we able to achieve those goals with available dental materials currently? In our practice-based research at Boston Prosthodontics, we've been trying to answer that question. And now, with over 5,500 restorations of Emax lithium disilicate and almost 40 years of research on different types of ceramics and 20 years of research on Emax, we're finally starting to have some evidence-based answers. And the questions that we had about survival, about the performance of Emax lithium disilicate restorations, we published on those. And these are the 3 papers that I will start presenting to you. The first one was on the survival of crowns fabricated out of Emax lithium disilicate. We had almost 2,000 restorations in over 500 patients and followed up at 10 years. The survival at 10 years was 98.3% with 7 failures. We looked at the performance of monolithic and bilayered restorations, and the fractures that happened, the failures, irreparable failures and fractures happened in monolithic restoration. It is not because monolithic are better than bilayered. It's because those were in the posterior dentition. So all the fractures happened in posterior dentition and 0 in anterior. But overall, if you look at the survival of 98.3%, it is very encouraging and reliable material. And even if majority of all the fractures happened in monolithic group, there was still no statistically significant difference. However, among the opinion leaders, which all of you are, we very well analyze that we should be practicing minimally invasive dentistry, and it's reached a state of widespread approval. And what is minimally invasive dentistry? It is early detection, diagnosis, and perception of the disease, treatment, and preservation of what's healthy. And if you look at Crohn's complete coverage restoration, they do meet all the criteria: detection, diagnosis of the disease, interception to stop, treatment. However, we know that it's more invasive preparation. It doesn't really preserve what's healthy because of less conservative preparation mode. And it's been very well quantified by Dr. Edelhoff and Sorensen, where they looked at the amount of tooth structure that needs to be removed for crowns and partial coverage restorations like inlays and onlays. When we look at the pictures, we can see the difference, but when you look at the numbers, it's even more striking, because with crowns, we remove up to 70% of tooth structure, as opposed to inlays and onlays, you can reduce as little as up to 30%. The same applies to veneers. There are static restorations, and because of the horizontal path of insertion, we only need to remove up to 30% of tooth structure. And again, the vertical path of insertion for crowns sacrifices more coronal tooth structure. So partial coverage restorations, they meet all the criteria of minimally invasive dentistry, of detection, diagnosis, interception, treatment, and preservation of what's healthy. We know that gold partial coverage restorations, they beat the time. These restorations are older than me, but these are our patients in the practice. The work was done by great and famous Bob Stein. That was the first owner of the practice. These patients are still coming on the recall and hygiene checkups, and the restorations are still in their mouth. However, like I mentioned, no one wants to have gold restoration in their mouth. Everybody is striving for a white aesthetic smile. And the question that rose next was, what is the clinical performance of ceramic partial coverage restorations? In order to answer that question, we looked at the survival of inlays and onlays fabricated out of emax lithium disilicate. We included over 550 restorations in 300 patients and followed up at 10 years. We had 6 failures. Again, when I talk about the failure, I'm talking about a bulk fracture that is irreparable and needs to be replaced because the restoration fractured and failed. The survival resulted in 95.6%. And I want to highlight that we use Kaplan-Meier survival that accounts for time in service and dropouts. However, the paramount question remains, do crowns have a better long-term prognosis in posterior dentition? So even if we prove that inlays and onlays have good survival, still I can hear among the general practitioners that in the posterior dentition, it is safer to go with crowns. So there is a tendency to automatically crown posterior teeth. And another question is emax too brittle for posterior dentition? Again, when it comes to posterior dentistry, general practitioners tend to choose zirconium as opposed to emax lithium disilicate. So to answer that question, we looked at the survival of crowns, inlays and onlays fabricated out of emax lithium disilicate, and in this time we only included posterior dentition. This award was, paper was awarded Jackson Hickey Award from JPD for Best Article in Research and Education, which I'm very grateful for in 2022. We really have large data, almost 2,400 restorations and over 700 patients, and almost 17 years of follow-up. We recorded 22 failures, and this resulted in 96.49% survival. If you look, the most important is that if you look at, again, when we reported survival of inlays and onlays, and it was 95, which is high, still the question remained, maybe crowns are better. But in in this paper, we compared crowns versus inlays and onlays, and you can see that there was no statistically significant difference in inlays and onlays and crowns. Again, I'm not saying that we should be putting inlays and onlays in teeth that don't have sufficient amount of tooth structure to provide resistance and retention for partial coverage restorations. However, if the tooth structure is sufficient, there is no need to automatically crown them, and this paper is a justification for those choices. For all three papers, the common finding was that no exponentially greater number of failures occurred over time. In other words, no long-term fatigue or degradation of Emax can be seen. Because Emax is only 20 years old, so how do we know that it will perform fine? Mouth is a very demanding environment. It's constantly humid, occlusal forces, interferences. So how do we know that lithium disilicate would not degrade over time? So these three papers show that there is no increasing number, which accounts and shows that there is no long-term fatigue. But still, we know that literature and science considered gold as gold standard. So I said, okay, how do our findings compare to gold standard? I went to famous Richard Tucker and Terry Donovan. They are the ones who are famous for the research gold. So I took their paper and see, okay, let's see what their findings are. They reported 90% success rate, 90.3% success rate at 10 to 19 years. And how does this compare to our study? If you look at the participants, number of units, our studies had higher, but regardless, let's look at the success and survival rates, 90% versus 96%. So maybe we are looking at a new gold standard. Additionally, Emax is an insulating material. It absorbs heat and cold and helps reduce tooth sensitivity that does not apply to metals. So maybe we're in the era where purple is the new gold standard. What does this mean to me? I don't want to be science heavy because this conference is meant for clinicians, practitioners. So what does this mean to me in dentistry? As a practicing prosthodontist, when this type of patient walks in my practice with loss of vertical dimension, lost function, and lost aesthetics, I take further evaluation and look at protrusive, and I can see that there is no anterior guidance and there is inadequate occlusion. I take more careful look, and this is classic failing restorations where generalized attrition. And again, why? Because we live much longer now. Before, life expectancy was less, so the dentition had to serve less time. Now the dentition has to serve much longer. So we see in orthodontics compilation of diseases, failing restorations, caries, wear, and how do we deal with that? So first thing I do, I remove all the failing restorations, decay, and assess remaining tooth structure. And I can clearly state that these will support partial coverage restorations. So I went ahead and I fabricated only type of partial coverage restorations. This slide shows CADX, which is an electronic pantograph. For our full mouth cases, both at Tufts University, where I teach the residents, and private practice, we do the tracing because we want to account for posterior determinant of occlusion. And here is the patient occlusal view, all posterior teeth restored with only type of partial coverage restorations. And now I have reestablished a vertical dimension, but at the same time, open bite. So now I have to restore anterior aesthetics because no one wants to walk like this with an open anterior bite, and as well as provide function, which is restore anterior guidance to protect posterior teeth from interferences. Partial coverage restorations have become so popular that some non-traditional approaches have been introduced. And one of them is to provide two veneers on a single tooth, one on the palatal for the anterior guidance and one on the facial for aesthetics. Some of the clinicians even use different types of materials. They put composite on the palatal and ceramic on the facial. And when I see some of them are my friends who do these techniques, and I just couldn't stop questioning why are they doing it? Is it because number of laboratory steps is increased, number of clinical steps is increased, treatment fees are higher because now I have to charge for 2 restorations per tooth. We have several bonding interfaces and no long-term studies. There are some medium-term studies, but again, with very low number of units. We don't know what's longevity. So I thought, okay, I know that crowns are generally associated with the pulpal damage. And there's a significant reason for the biological failure for prosthetic restoration is the pulp damage, loss of vitality. So I thought, okay, maybe the advantage is to preserve healthy and vital pulp because more conservative preparation, less invasive, less damage to the pulp, longer vitality. But as a researcher with PhD, I always like to question and then provide answers and try. At least I try. Of course, I'm never for sure, but we try. But is logical always evidence-based? So in our next study, we looked at the incidence of endodontic therapy in crowns, inlays, and onlays, and we wanted to see if crowns would result in higher incidence of endodontic therapy. And this paper was also published with the aim was to assess the incidence of teeth requiring endodontic therapy after receiving either complete or to IADR, and we received Neil Garrett Award for clinically focused and patient-centered research, which I'm very thankful for. It's very important that I report. I don't want to go into the details of experiment lay or crown, tooth position and arch, maxillary mandible and which tooth it was, restoration thickness. We measure the restoration at 7 points. We have mesioclusal, midocclusal, distocclusal, buccal-lingual, mesial, and distal. And we categorize the restorations into more than 1 and less than 1 millimeter. So 2 groups, 3 age groups, as you can see on the slide, 2 genders. And the participants were recalled every 6 months for clinical and radiographic assessment. The outcome this time was not a fracture. It was incidence of endodontic therapy. In other words, the tooth was vital and they received either inlay, onlay, or crown. And over time, how many post-prosthetically would need root canal therapy? Now here we also included the Empress data. So the number of units is over 4,500 with anterior crowns, posterior crowns, and posterior inlays and onlays. You can see the breakdown on the slide. And we had 1,800 participants. Over 30 years, this 4,511 restorations, 76 of the teeth needed root canal therapy, which by direct calculations is 1.68%. And you can see that 10 root canal therapies occurred in anterior crowns, 50 in posterior crowns, and 16 in inlays and onlays. This is the overall findings in one table. You don't have to look and study it because I'm going to walk you through separately. But overall survival was 97.36%. And the only statistically significant difference we saw was between anterior crowns and posterior crowns. Posterior crowns needed more root canal therapies. And interestingly, anterior crowns and posterior inlays resulted in more root canal therapies, which was, you can see that the majority of root canal therapies occurred in molars, first and second. Gender was not a factor. Men and women, they performed similarly. Age was a factor, which was also a surprising finding for us, because I was thinking that younger people would result in higher incidence of root canal therapies because of the wider pulp chambers, but we saw that the older group, more than 53 years old, had the majority of the root canal therapies. In other words, 58 out of 76. Ceramic thickness, that's not a surprise that the thicker restorations, more than 1 millimeter, resulted in majority of root canal therapies, 64 out of 76. Mean time in service was 11.2 years. Average time to root canal therapy required was 4.64 years, and most of the root canal therapies, 58 out of 76, happened within first 5 years. In other words, if there is a damage, it shows itself within first 5 years if the pulp was stressed, and it will not occur idiopathinally later on in years, less likely. The first question is the data that she presents reliable? Is 1.68% over 30 years reliable data? So why don't I walk you through that question by looking at various factors? Not only the preparation technique that we are so focused on when it comes to crowns, but also where the study was done, hand skills of the providers, treatment efficiency, preoperative condition, ceramic thickness, cementation protocols, and the choices of the materials. So if you look at the literature, the reported maximum varies of the root canal therapies. It's from 1 to 19%. And most of those studies were on metal ceramic or early ceramic restoration. So first, that there really was need for this type of study with the modern ceramic materials. Secondly, I made this table, and if you look at two top studies, you can appreciate that the survival was only in 80%, like 86%, which is very close to our 97%. And why there is such a difference? If you look at the two top studies, they were conducted in a teaching institution, hospitals, dental schools, and two bottom in the private practice. And we want it or not, operators' hand skills, they account for the success. Dental students cannot do the same level work as an experienced clinician will do. Treatment time and efficiency is different. The diagnosis is less likely that a pulpal diagnosis will go unnoticed in an experienced practitioner. And we're also dealing with different patient clusters. The patient cluster that goes in private practice has a different dental IQ from those in dental schools and teaching institutions. Now, we saw that anterior and posterior restorations, there was difference, right? Posterior crowns had higher incidence, but interestingly, posterior inlays also had higher incidence of root canal therapies. Now, to explain that, again, I go and see what's out in literature. And I like this study because they looked at incidence of root canal therapies required for loss of pulpal vitality in teeth, and they categorized in two groups: intact teeth that were receiving crowns and preoperatively diseased teeth that were receiving crowns. Preoperatively disease meaning existing fillings or recurrent decay, and intact teeth, I really don't know why they found intact teeth, because I tried to look in the paper to see the rationale, probably for global diagnosis where the full mouth reconstructions are done. But they had two groups, and what they found that the higher likelihood for the pulp necrosis to occur in preoperatively diseased tooth as opposed to in the intact tooth. It was 8 times higher likelihood in the preoperatively diseased tooth to develop pulp necrosis. So maybe we're dealing with the stressed pulp condition. Now, when we look at them as intact and preoperatively diseased, but we can see that majority of root canal therapies happen in molars. And we know from literature, again, that molars have the highest prevalence of caries. So it's more likely that they would require root canal therapies. And also molars have more complex pulpal anatomy. And unless you're raising the vertical, the second molars, you always fight with occlusal clearance, and you're never sure if you're getting too close to the pulp, and there's always limited restorative space. That also explains why inlays resulted in higher incidence of root canal therapies as opposed to onlays, because onlays is always a treatment for where inlays is more treatment for caries. So caries is already causing a preoperative condition that stressed the pulp. So it's not the crown, it's not the inlay, but where the tooth was as an initial status. Ceramic thickness, the thicker restorations have higher incidence, and it's not surprising because we removed more of the tooth structure. But the paramount question is, can Emax perform at less than 1 millimeter thickness? We also answered that question, and we'll compare that to survival of more than 1 and less than 1 millimeter thickness restoration, and there was no statistically significant difference. So as educators, I think we should raise the awareness that maybe we need to upgrade and change the protocols even for the crown preparation and reduce amount of tooth structure that we are removing even for the crowns. Now, the opinion leaders are so focused that crowns are invasive that we forget that there are other contributing factors like cementation protocols and material choices. In our practice and in this research, we religiously, regardless of the thickness of the lithium disilicate and resistance and retention form and the height of the tooth structure, we always acid etch ceramic and apply silane, and we also acid etch with phosphoric acid the tooth, apply gluma desensitizer, followed by dentin bonding and resin cement. Now, when we use glass ceramics like Emax, it belongs to the family of glass face ceramics, and when we etch with hydrofluoric acid, we remove the glassy face that creates that porous surface that accounts for really strong bond between ceramic material and dental substrates. Now, on the other hand, we have enamel and dentin, and they're covered with smear layer that is a cutting debris that is full of, but we achieve more intimate adaptation between resin cement and dental substrates like enamel and dentin. Gluma is contains glyceraldehyde, and hemaglyceraldehyde is a natural fixator, and it occludes dentinal tubules, but it's also been shown that it inhibits MMPs and increases resin-dentin bond long-term as well as immediately. Now, HEMA enhances sweating properties, so that adaptability is much better. So if I usually use Gluma even after, instead of immediate dentin sealing, I use Gluma. I prepare the tooth, and before I place the provisional, I apply Gluma. And again, I apply Gluma right before cementation. One, postoperative sensitivity is decreased. Two, resin-dentin bond strength is also increased. In terms of resin cements, we know that they have lower solubility. They enhance ceramic properties. That's been shown both in vivo and in vitro that if we use resin cements, mechanical properties of glass ceramics is improved. And if you look at bond strength, the bond strength that is achieved between resin cements and lithium disilicate is highest that you can achieve, because this is the combination of Variolin, the blue, with lithium disilicate, and you can appreciate how much higher it is above zirconia, even with the APC protocol and Panavia that's been shown to be the best zirconia bonding out there. So overall, adhesive cementation has increased resin-dentin bond, reduced micro leakage, reduced micro motion, improved post-insertion fit, and we think that also reduced pulpal irritation and damage. One of the reasons we think that we were so successful and so little pulpal damage occurred over time is because of reduced pulpal irritation and damage over time because of adhesive cementation. Now, when we look at posterior crowns, inlays, and onlays, yes, there was difference between anterior crowns and posterior inlays, but between posterior crowns, inlays, and onlays, there was no difference. In other words, if tooth needs buccal occlusal, lingual, medial, distal coverage, there is no advantage for going with multiple restorations, because trendy is not always evidence-based. Again, if you choose veneers, palatal and facial, you should understand that there is no resistance and retention form, and only retention we have is bonding. We're solely relying on bonding. And if we're relying on bonding, we really need to know what are we bonding to. Is it a ground enamel, the virgin enamel? Is it ground enamel? Is it dentin or other dental materials? If we look at unground enamel, it's not ideal for bonding because of the aprismatic layer. We cannot really etch it as well, so there's always increased micro leakage over time. Do you want to have micro leakage with veneers? Absolutely not. The whole purpose of aesthetics is defeated there. Now, in terms of dentin, when we look at Galip Ural's research, that is the father of veneers, he had two groups: intraenamel veneers and dentin exposed veneers. Survival at 12 years for enamel-only veneers was almost 99%, which is excellent. I'll take that any time of the day. But if we look at the dentin exposed, survival drops below 70%. Now, if you mention that to your patient that investing $60,000 in the smile makeover, maybe they'll go for crowns if they don't have sufficient amount of enamel. Because when dentin is exposed, micro leakage, debonding happens, and when there is debonding, veneers are only 0.3, 0.8 millimeters. The only reason they're strong because they're luted and cemented, bonded to enamel. But if there is micromobility, the veneer can very easily fracture. And why are we going to have micromobility? Because dentin bonding degrades in 2-3 years due to the MMP's digestion. bonding degrades, and there is mobility, and eventually higher risk for failure that was shown to be 68% survival at 12 years. Now, in terms of other dental materials, there is really not much studies that show that bonding of ceramic veneers to existing composites. Now, the bigger question is, do we choose direct composites for veneers, inlays, and onlays, or we call them fillings? Or should we go indirectly ceramics? Because if we do indirect restorations, even with inlays and onlays, we're always more invasive because you need to achieve certain paths of insertion. You need to remove the undercuts. You need to have divergent preparations. You can block some of them, but overall, you need divergent preparations. Now, let's look at the literature. I love this study because they looked at very large data, and they looked at the outcome was reintervention. How many composite fillings will need to be retreated? And they had 1 surface, 2 surface, 3, and 4 and more surface restorations. And you can see that reintervention rate outcome, the survival is only 62 and 63% at large composite restorations. And if you look at the cumulative success rate at 4 years, for 4 and more surfaces, survival is only 55%. So now you tell to your patient, I'll do composite filling, it will be cheaper, it's less invasive, but there is a 45% likelihood that in 4 years we'll have to redo it. Now, what's more minimally invasive? Now, and then I wanted to make this table for you where we looked at the control studies and the database studies. If you look at the control studies for composites, the failure rate is 1 to 3% a year, as opposed to 0.3% for ceramics. And if you look at database studies, it's up to 9% for composites and up to 1.3% for ceramics. So I believe the price, as well as the preparation technique, as well as 1 extra visit, is very well justified by the excellent survival of lithium disilicate. Now, when we look at this, you see all this micro leakage and recurrent decay. Is this truly minimally invasive? How long should the restoration last, and how many reinterventions can patient afford, both psychologically as well as financially? Because I believe that we should not only focus about being minimally invasive, but also consider the secondary prevention, the time in service. And when I talk about time in service, I mean the restorations need to survive without fracture. There shouldn't be bacterial adherence. We need to prevent recurrent decay and maintain occlusal schemes, because wear is the same disease up to 29% of the population. So if I give something that wears away within 2 or 3 years, then I have to redo it. So the case that I'm presenting, where I increase the vertical dimension, should I go with a sandwich technique, which is the 2 veneers on 1 tooth, or do just a crowns? So I chose for this rationally. There was no advantage to 2 veneers, so I went ahead and I crowned those anterior dentition. And this is the patient in centric and protrusive, where we provide mutually protective occlusion, where anterior teeth protect posterior in protrusive and lateral intrusive movements. And this is the patient before and after. I think minimally invasive dentistry is the way we should be practicing, but it needs an upgrade. And I actually just submitted the paper, the commentary review paper about this, to a special issue of Journal of Aesthetic and Restorative Dentistry, that we need to consider time in service, because we need to be as minimally invasive as possible, but as invasive as needed to prevent the disease from recurrence. Now, wear, this is the slide from my sister. She's an anthropologist, and the wear has always been a problem for hominids. And you can appreciate how much tooth structure loss this individual from 2 million years ago developed. At that time, the food was much coarser and teeth were used for holding certain instruments. We are not there now, but the severe wear still persists among our patients. This is a patient of mine, and he brought the picture from 42 years ago, and you can appreciate the amount of tooth structure that he's ground through. Take a closer look, reverse smile line, an appealing appearance, significant amount of tooth structure loss. We look at the protrusive movements, and there is no anterior guidance, so posterior interferences. And classically, even though the tooth wear has been categorized into 4 different categories of chemical, attrition, abrasion, which is mechanical, and non-pericervical lesion, we see combination. It may be starting with attrition, but then erosion also plays the role. So we see combination. Again, this patient was in his late 60s, but he has another 30, 40 years to go. So now the dentition has to serve us much longer. The question is that can we provide tooth color restorations to the patients with severe wear? Because when there is severe wear, there is always potential thought for bruxism, and bruxism is increased occlusal activity and higher occlusal loads. Can we be minimally invasive? And how long will these restorations last in patients with severe wear? So the next paper, also published in Journal of Prosthetic Dentistry this year, the aim was to assess the survival of lithium disilicate glass ceramic, complete and partial coverage restorations in patients with severe wear, and compare the two. Outcome is about bulk fracture that is irreparable and needs to be replaced. And this is the example of the bulk fracture. Here we had 53 patients and 662 restorations, and the breakdown is as follows. Anterior crowns to 64, posterior crowns to 87, and posterior inlays and onlays 111. We had failures, of which 4 happened in posterior crowns and 2 in posterior onlays. As you can appreciate, 0 happened in anterior crown. So yes, there is this tendency of multiple veneers on the anterior teeth, but there is no higher incidence of root canal therapy. There is no fracture, so really there is no benefit to that. We had 14 years follow-up. Survival was 98.6%, and 5 of the 6 failures occurred within the first 5 years. So again, we see that there's no cumulative damage. Overall survival was 98%. Anterior crown survived at 100%, and the lowest survival was seen in posterior onlays. That was 85.68%. Again, is it horrible? No, 85% is still high for 14 years. Dental arch, maxilla and mandible have equal distribution of the failures, 3 each. Tooth position, like I said, all the failures happened in the posterior dentition, mostly molars, so that was a factor. Gender, interestingly, we know that men have higher incidence of we all know that men have higher occlusal load. So we were expecting that higher failures would happen in men, but that didn't happen, not in bruxing and severe wear patients, nor in the full data set. For EMAX, lithium disilicate, this is the first glass ceramics where we do not see difference between men and women. Age was not a factor. Again, we didn't see an exponentially greater number of failures over time, so even the severe wear was not a cumulative damage for EMAX lithium disilicate. Now, is my data reliable? Let's compare it to the literature. If we look at Grach's paper, overall survival, 98% in patients with bruxing for glass ceramics. Systematic review that came out in JPD in 2018, there was no association between bruxism and failure of ceramic restoration, but all of them were a retrospective study. So the power of our study is it's a prospective study. So there was really room for such a paper in the literature. Big person in restorative materials, Dr. Edenhoff, it's 7 patients, 11 years. 100% survival. So we're not making it up. The literature is very comparable. Higher incidence of failures happened in onlays when it was compared to anterior crowns. Again, there was no difference between posterior crowns and posterior onlays, but there was difference between anterior crowns and posterior onlays. That was the only statistically significant difference that we saw. Again, no difference between posterior crowns and posterior onlays. We took the CADIX electronic pantograph for this patient before he was provisionalized, so that all the diagnostics was done with accounting for posterior determinants of occlusion. This is the patient with provisionals at re-established vertical dimension. day of final impressions, and Emax lithium disilicate single unit restoration supported by teeth or implants. And this is the patient after. You can appreciate mutually protective occlusion with posterior disclusion and protrusive and lateral intrusive. And patient has the smile that is remarkable, confident, and durable. What I love most of all, that it's radiolucent. I can see what's going on underneath. I can see if there's decay. I can see what kind of foundation restorations I have. This is the severe Braxer patient at 6 years follow-up with no fractures and no chips. So how long will these restorations last? I think it survives without fracture rather well in the form of crowns and inlays. Onlays have higher incidence of fracture, but yet 85% at 14 years is rather reliable. Now let's look at the maintenance of occlusal skin, which is very important factor for severe wear patients. Because a lot of people restore vertical dimension with composites. But let's look at that slide in the studies. I borrowed that from him. He looked at the wear patterns for lithium disilicate. This is the amount of wear that he detected for lithium disilicate at 78 months. And then he looked at this is the surface at 16 months. So that's strikingly different. And if you look at the quantification in numbers, composite wears approximately 3 times faster, both in first and second year. And if you look at the natural rate of the enamel wear, it's 13%. So natural enamel and premolar wears at 13 microns, composite at up to 25, and lithium disilicate 9.5 microns, which is very close to natural enamel wear. So maintain occlusal skin is absolutely, I'll go for glass ceramics over composite any time of the day. Now let's look at the bacterial adherence. They looked at the survival of composite and ceramic. Ceramic survived at 100%, composite 84.7%. We're talking about 2 years only. This is nothing. Up to 3 years. This is nothing, right? So you have this level of survival at 3 years. It's really scary. And the reason for failure was surface roughness and degradation. And we know that if surface is rough, bacteria loves it. So the pellicle formation, the plaque accumulation will be much increased. That will technically and theoretically promote recurrent decay. So if we compare resin composite with ceramic, there is no question that there is higher chance of bacterial adherence and recurrent decay with resin composite. So if we look at the patients with severe wear, can we provide tooth-colored restorations? Yes, I can recommend that. Can we be minimally invasive? Yes. And how long will it last? The survival at 14 years is 98.6%. So these are all the patients that were included in the study, and they've been with lithium disilicate restorations. And I had to make a few slides about zirconia because when we talk about severe wear patients, I think automatically we tend to choose zirconia. So I said, okay, let's look what's the survival of zirconia. And one, there's not much studies because if you look in PubMed, most of the studies are systematic reviews, literature reviews, and the question is, what are they really reviewing? There are not too many studies, not too many quality studies. And I took the most recent systematic review on the survival of zirconia restorations. And first look at the follow-up time, 0.8, 0.3 years. The longest follow-up time is 2.1. And in prosthodontics, 2 years is equivalent to provisional. So it doesn't tell me anything. I need 5 years and more to choose the material reliably. And the study that had largest sample was 148 units. Survival at less than 1 year was 93%. Now that is scary to me. Then they looked at the fixed dental prosthesis for zirconia metal ceramic. Metal ceramic has higher survival. And then they looked at the single crowns for new site, reinforced and lithium disilicate at zirconia, and they both, new site reinforced and lithium disilicate, so glass ceramics had higher survival than zirconia. Another study overall findings of this systematic review, all the papers put together, their number of restorations was above 1,600. We had about 1,900. Survival time, follow-up time was up to 2.1 years, again, equivalent to provisional. We had 10.4 years, and the survival was higher for lithium disilicate. I know that our studies have limitations. It's coming from one practice with very experienced and board-certified prosthodontists. There's no blinding. We have a master dental technician that does all the work. So you can't generalize those findings to general practitioner out there because the quality may not be the same. But on the other hand, we don't have factors of hand skills and master technologists influencing. We're truly looking at the true outcome of the survival, the fracture resistance, the true outcome of incidence of root canal therapy with other contributing factors. And I know it has limitations, but I also know it's so hard to achieve evidence in prosthodontics because the bar has been set so high by Craniofacial. He said you need to have at least 500 restorations over 5 years. Peter Scherer said also 5 years of research, 95% survival. And Patterson recently published that you need to have at least 1,000 patients and 5 years of follow-up to have a clinically relevant data. So be cautious when new ideas are presented without true evidence. We can explore new ideas. We can definitely explore new ideas, but we cannot preach new ideas until we have the evidence to support these new ideas, because the price is very high for the failure, because the price is paid by the patient, both financially and psychologically. It is not fair to them, because without the data, we're just people with an opinion, and we cannot preach the opinions. And regardless, when I go to the conferences, when there is recurrent decay, no one wants to treat the tooth anymore. Tooth catches a cold, they take it out, replaced by the implant. We have this jump. We bypass therapy, bypass the crown lengthening. We're straight into implant because, and it's a dental paradox. Either we're into this micro-invasive dentistry where we are encouraged to work with a microscope, or we go and we see the super aggressive extractions, edentulate the patient, and provide implant retained restorations. Implants are forever. That's the perception. And the data that to support that, and I'm pretty sure it's very often company driven, not necessarily the doctor driven, is that the survival is 98% at 10, 15 years. So you tell to the patient, well, you're going to pay for root canal, for crown, for this and that. And, you know, the question that the tooth will still have questionable prognosis, whereas the implant is bulletproof. Of course, the patients will go for implants, but what are long-term implant considerations? First, survival is different from success. And my friend, Dr. Panos Papaspiriakos, published this in 2012, that implants is a different animal. The fact that it's in the bone and it's still present, it doesn't mean that it's fully functional implant. Because implant complications with the recession and bone loss in the aesthetic area, we should look at the implant and the crown as a single like a one organic factor, not just the fact that the implant is in the bone. So success is different from survival. And then implant has its own continuation story. We forgot that the implant has peri-implant diseases. If you look at the data, peri-implantitis is up to 10% prevalence, which is manageable. But we have prevalence of perimucositis and then mucosal recession. So altogether, the peri-implant problems are there. They not only cause damage to themselves, obviously, so there is a peri-implantitis, it's a problem for an implant, but it's also been shown that teeth that are adjacent to untreated peri-implantitis are associated to proximal loss of periodontal support. In other words, there is collateral damage from the peri-implantitis. Open proximal contacts. How many times you place the restoration, patient comes back, within 2-3 years, you see the proximal contact opens, and they're like, I could not have possibly delivered that. It's been published by French that up to around 27% of implants will have their mesial proximal contact open by 8 years. At 8 years, why? Because there is mesial drifting of the teeth. That's natural. That's part of our aging. What happens with implants? They're ankylosed, they don't move, so the proximal contact opens. Do we warn about this to the patient? How are we going to repair this? You're going to unscrew it and place it back in the oven and the whole thing blows up? There is a financial factor that patients need to be warned about, as well as the doctors. Another paper published 34% open proximal contact at 10 years. This paper, I love it because it showed the problem that we all see in the clinic, but it documented and reported it. The teeth next to implants are more likely to develop root caries. Usually we see root caries in around 3% of teeth, but here we see root caries in 17% of teeth. And that's accelerated and exaggerated if the implant is placed 4 millimeters and further away from the tooth, because of the type of emergence profile that we need to develop is not cleansable. So then the bacteria becomes more virulent and it attacks the root, and we see this collateral damage. This is why we need to take advantage of correct three-dimensional implant placement, statically driven placement that can easily be achieved by computer-aided implant surgery. It is not just a fancy tool, but we should really take advantage of this to have more predictable long-term outcomes with reduced collateral damage and reduced long-term complications. This has been published, Dr. Weber, my forever mentor, we published a chapter about the computer-aided implant surgery in the new edition of Digital Dental Technology. Another factor that no one talks about, or some people talk about, is the infra-occluded dental implants. In the anterior zone, teeth continue to erupt, and then we see implants that are implant crowns that are shorter. This has been shown that happens more often in younger women, hyperdivergent patients. So at what age can we place implants in the aesthetic zone without expecting infra-occluded dental implants? This is a patient of ours, 62-year-old male. Right side is on implants, left side is on teeth. You can see the 5-year follow-up, supereruption of the teeth side. Now, I'm not saying that we shouldn't stop placing, we should stop placing implants in the aesthetic zone. Absolutely not. But maybe we need to plan with more precautiousness and delay where indicated. Provide a retainer to keep the teeth in place. And maybe we need to warn the patients that this is a potential long-term complication. And we appear much smarter in patients if we warn them about possible complication as opposed to coming up with excuses. So if we told them this might happen, it happens, they were psychologically prepared. And it makes us look smarter too. Technical complications. We see that it happens more often from screw loosening to screw fracture. And again, it's all finances, it's shared time, it's expense both to the practice as well as the patients. So I started my implant section with a slide where it says implants are forever. But if we borrow Dr. Ricardo Vitrani's words, that's the biggest dental lie. The biggest dental lie that implants are forever. And I would say that implant survival is high, but complications and age-related long-term changes will happen. So why are we accelerating? Teeth, the success between teeth and implants is without statistically significant difference. But if you look at need for intervention, price, and number of visits, it's statistically higher in implants. So teeth are easier to maintain. Maybe implants are easier to restore because it literally requires no skills, but teeth require less intervention. So what's wrong with using post-in course with severely damaged teeth? Survival, 92%. This is a systematic review that I published together with my mentor, Marco Ferrari. Another study that looked at extensive restorations. The main reason for referral was need for full mouth reconstructions. They looked at 78 patients at 10 years, 74%. It's not high. The survival is not high, but it's not low either. For 10 years, 74% to extend the tooth, life of tooth. Let's look at the tooth preservation versus periodontally compromised patients. This came out from the Greek group. One of them is my dear friend, Dr. Mikalakis. There is no difference. And their suggestion is that treatment of periodontally involved teeth with maintenance protocol is a viable alternative for several years before proceeding to extraction and replacement with dental implants. And again, I cannot highlight and stress enough that we need to consider patients' age. If someone in 70s comes to you with periodontally compromised teeth, maybe we can feel safe to extract because we know that 20, 30 years the implants will be fine. But if someone walks in my practice late 30s, early 40s, and I edentulate them now because implants will have no problems, that's not fair. If we look at teeth, survival, virgin teeth, they are God-made and they will survive and beat anything. It's 99% at 50 years. But if we look at compromised teeth and implants, the survival is similar. If anything, teeth do better. So is this really terminal dentition? I didn't do this. It's from Instagram. One of my colleagues posted it. This patient was edentulated and provided implant retain restoration. And I'm sure the patient's young. Now, these are our patients. In many practices, they would have been edentulated, but all of them were reconstructed with teeth retained restorations, and they kept their natural dentition, their proprioception. I'm not against implants. I do a lot of implant placement and a lot of implant restorations. They all have implants. All I'm saying that we have to take a thought before we jump into extracting the teeth, because now we have increased life expectancy, and we need to look at the survival, not at 15 years of implants, not at 20 years, at 50 years. This is a patient of ours that had implants. So she did full mouth reconstruction and then eventually teeth failed. She got implants. They were there for 20, 25 years, but now they're all failing. And you can see that for some of the implants failed. One, we no longer place so many implants. She got the implants at the time. You can see the external hexes. These are very old implants where we thought that we need to place implant in each missing tooth. But now we know that implants are a different animal from teeth. We don't need as many implants as teeth. All the studies show that for full arches, 5 and less implants do better than 6 and more, because in implant scenario, less is more. So eventually we can see that all the implants in this patient is failing, and she has to go for the 5th dentition. We took all the failing implants out. I could not do the immediate placement because she literally had no bone or place where I could place the implants on the day of explantation. So she has to be in partial, immediate complete denture. And Dr. Weber responded really, so this was, surgery was done by Dr. Weber, and we were saying, so, oh, Dr. Weber, the implants are forever, right? And he goes like, yes, implants are forever, but not necessarily in patients' mouths. My second message, so the first message was that in minimally invasive dentistry, we really need to consider secondary prevention and time in service. And my next message to the attendees out there is that please extend the lifespan of a tooth and do not accelerate the process. Time will show when the implant is right, but do not accelerate just because it's company and finance driven. Thank you for your attention. And I'm gonna stop my sharing here.
Thank you very much. Thank you very much, Professor Mariam.
I was able to go over time. I'm sorry if I went over time.
Not a problem, but this is an impressive study.
Thank you very much.
Research results which are vital to be able to deliver quality dentistry, reliable dentistry to our patients. And this is very important. And you made brilliantly this study. Thanks again.
Thank you very much.
Mariam, many thanks for your very interesting presentation.
Thank you.
Well,
all right. I apologize in the beginning. My son was leaving and there was a lot of noise, so I apologize if there was background noise. And I wish everyone a nice weekend.
Thank you, Mariam. No, it wasn't any.
No questions. All right.
Thank you very much. Yeah.
Thank you.
Yeah. So the next try find the next. He has completed his degree in dentistry at the University of Buenos Aires in 1974. He achieved the postgraduate degree in functional orthopedics in 1918. Italy, the United Kingdom, Switzerland, and Spain, as well as pursuing ongoing research and teaching activities through the MPR International School and in collaboration with other institutions. Without further ado, I would like to invite Professor Silverio Di Rocca to make his presentation.
Hello, how are you, everybody? I think you listen well my voice. Yes, it's okay. Yes, you listen. Yes, thank you so much. Thank you so much for the invitation. It's the third time I think we share knowledge about all the world. Okay, I would let me go here and then. I think now you see the presentation. Yeah, you can see that. Yes. Yes. You see the presentation. Yeah. Okay. I see the presentation here. I don't know if you see the presentation. Are you seeing that? Yeah.
Yes, we can see it.
Okay. I will. Today's very difficult for me. You know, I have 50 years working in dentistry. 50 years is a very, very, very long time working in dentistry, and I see a lot of changes in dentistry all around the world. I live in many countries. I work in many countries. And I am a special dentist because now diseases. To talk today about something that is our craniofacial system. That is very important to understand why I am telling that. And the relation with the posture. Many years ago, I talking about in 2004, I was invited in one meeting for a group of implantologists. I was listening to the talking before with the doctor, very impressed with the talking, and I was thinking, how can I explain the implantologists this concept? Because they look only screw teeth and nothing more, and was implantologists and technicians. You know, 1,200 people you have to talk in the meeting. And I started, I don't know what happened in my mind, and I started the conversation, the meeting, the presentation like this. I said, listen, tell me if anybody in the room have never had a failure in the treatment, please raise the hand. And everybody look one way or the other. And I said, listen, don't look around because always we have failures. Everybody had failures in the treatment. Myself, you, and say, oh, technician, crowns of the technician, they said, oh, the implantologists don't take a good impression. They don't make a position good of the implant. And then they both are together. They say they broke in my restoration. I say, I think we never ask why. We have a failure. And maybe it's because we have a different point of view in diagnosis. I born as a dentist 50 years ago, plus 7 years of university, 57 years, many, many years ago. I learned about it. Everybody is learning about it. That moment, very, very important. And later, I start to study posturology. Imagine posturology. What is posturology? What is posturology? The connection between the whole body. And I have a school, we create a school, it's an international rehabilitation, and we teach that for all medical sciences, from the doctors, dentists. I understood there was a connection between our system, which is craniofacial system, and the rest of the body. And in this moment, I said, I was with my professor in France, and at that moment, I didn't know what is posturology. I said, I believe, but it's by faith, because I don't have experience. But if you are telling to me these things that that was an orthopedic surgeon. You cannot work in posture because our craniofacial system are disturbing your job. And you said to me, I cannot do a good job if the posture is not good. We have to start to work, because I cannot treat the craniofacial system in one day. And in that moment, in my mind, I told him that 40 years ago, work together the whole medical sciences. And we create an association with the Swiss International Association of Posturology. I am the vice president of this association. And we're talking with all medical science to see the patient in the same point of view. And that's a little CV, just a little. Yes, not too long, but just to know where I am. I am a dentist, but I am a dentist who changed the mind to see the job. And I am not telling we don't have to be dentists. You have to do a good restoration. You have to do a good implant, a good. The most important thing, in my opinion, is to see how our craniofacial system can disturb the rest of the body if it is not in a good function. And that is, in short explanation, the topic of my presentation. We were talking about craniofacial system dysfunction. Yeah, we were talking, I want to introduce you the posture also, because posture and posturometry, how we measure the posture, because that you will understand why I am telling that. I start to measure people in posturology in 1999. I measured more than 10,000 people. And I discovered what happened when our craniofacial system is not working well, how, in my opinion, it's a very difficult concept to understand immediately. Many years ago, for me, was the same. But we are connected. We cannot work only the teeth, only the foot, only the eyes, only one part of the body. We have to work in the whole body. I create this protocol that is myofunctional postural rehabilitation. Why I am telling craniofacial dysfunction? Sometimes the people said, I'm specialist in TMJs. And imagine if I said to you, I am a specialist in a finger. What do you say? You're crazy, no? The finger is part of the hand is part of the arm is part of the body. TMJs is part of craniofacial system that is connected with the rest of the body. When I start to study posturology, I understood very well. That's why we dentists have to be more attention to TMJ. And I try in that small presentation, I try to explain synthetically why I am telling that. Craniofacial system. TMJs is temporomandibular joint. Temporalis is part of the cranium, and the jaw is part of the face. We are connected. And this joint is connected with the cranium, with the neck, and with the rest of the body. Sometimes I was listening with attention the research of the professor before me. And the research only look, I am many years ago with implant, and I did all the specializations in 50 years. Imagine, I work in all the specialization from the decay until the rehabilitation. I choose craniofacial orthopedics and functional orthodontics. Now, and postural disease, that the things we are occupied now. But all the researches are looking at what happened to the rest of the body. And imagine, I am saying, when some teeth is broken, it's for something. Dysfunction. If you don't absorb the fracture, it's broken. But sometimes it's not broken. But we study what happened with the neck if it's not broken, because its resistance is still there. The same for orthodontics. No relapses. But with the mystery, do a research for insoles, never see what happened with the jaw position. Even the physiotherapists, when they do some treatment, they don't see what happened with the jaw position. And we, dentists, we don't see what happened with the rest of the body. Many years ago, I started to study that, and that's why I am very happy to talk about craniofacial system. Craniofacial system is a very important system. TMJ is just part of the system. We can not, and is a big disturber of the posture. Very, very big disturber. That is the thing I teach. This is the area of TMJs. Cranium and face connected with the hyoid system and the neck with the rest of the body. Sometimes, and I was learning orthopedics many years ago, also we do a change of the jaw position to stimulate the growth, because we have to do a therapeutic change of the jaw position to stimulate the growth. What we never see, if they change, is accepted for the rest of the body. Postural problem in a child is very important. In a child, I focus on the child, because in the child you can prevent the future with craniofacial orthopedics. And when we have an harmony, good health for the patient. But what means that? We means a good jaw posture with the rest of the body. I started to work in dentistry, as I told you, central relationship, central. You have a lot of definition, central relationship, but nobody said the central relationship with the rest of the body. Central relationship only with the jaw. And we cannot have a good central tension if the body is not in balance. Thus, because we static posture, notions about tonic postural system. Imagine tonic postural system. How do we need the best for the muscles? To have the skeleton, is the main director is the central nervous system, who have a peripheral receptors who send information to the central nervous system. He elaborated the situation of the environment and created a muscle tone of the body. Imagine, muscle tone of the body, craniofacial system have muscles as a body, neuromuscular system. And that's information is arriving through the main receptors. We have a good antenna in our body who arrive the information to the system, the central nervous system. So, mainly the receptor and sending back the information, and it's creating a cybernetic system. It clocks even if the information of the receptors are wrong. Imagine if the foot support is wrong, if the oculomotor system is wrong. And the other receptors sending wrong information, the answer is wrong, and we create an adaptation. Some of the scoliosis related with all the things I am telling. Just 5% of the scoliosis are structural. And in the middle of the receptors, we have a craniofacial system. The stomatonia of the is not in balance. Oculomotor system is movement. When we have a good movement, we have good peripheral vision. This is the research I did many years ago, 1991. Please focus that. Jaw position, central relationship. When it's not good, is creating alteration of one of the main receptors, who is the oculomotor system. Lateral deviation are creating, we call hypoconvergence, unilateral hypoconvergence. And the affecting both eyes, creating bilateral hypoconvergence. Say, what you study is creating alteration of the posture, overload, lateral, right or left, and changing of the very center of the body. Yeah? Craniofacial system is connected with the yoid system. Yoid system is a special system in the middle between cranial, neck, and body, who is connecting the foot with the eyes. And what is the relation with the static posture? How the craniofacial system is affected with the changing of the position? That what we are focused forever, dentists, in the central relationship, but we don't know why. We say we have to do that because our rehabilitation have to go in a good relationship. It's good, but this job, and that's important. Yoga system changes in the mandibular position when the jaw position, try to simplify. When the jaw position, the traction but it's not resisting the life. And the central nervous system have a defense. They said it's an automatic defense. The teeth are blocking a jaw who is wrong. This is dangerous. Sorry, it's starting here. It's starting here. Telephone. When we have the brain said defense of the activity, cranial muscle hyperactivity, and slowly is going down, and it's altering the whole muscle change, and it's creating postural and chronic alteration. That's happened later. That's why I am fanatic. When the system starts in the moment, oh, sorry. the presentation in that position. That's how change position is dangerous for the system. Is an alarm, say, from the top to the bottom, very slow, many chronically, we're starting to create a disease. A disease, craniofacial, we look only these show TMJs, but not see the rest of the body. And even the doctors, it's not only that, but it's very difficult in short time to explain that. But the effect, I say, I want to kill grandmother. Yes. My grandmother was very stranding, creating bias. With the parafunction, they are testing the teeth occlusion. If the functional areas are good, if the vertical dimension is good, if the muscles are good, if it's not, they say, okay, these are the lock who are creating problem in the TNJ, we got to destroy the teeth. Very bad defense. And when something happened on the top, we have the connection with the rest of the body. The upper hyoid system and the lower hyoid system. And slowly, we are going from the top to the bottom, creating alteration. This situation retroposition. And even if we have lost the vertical, it's creating hyperactivity with the systems there. First, slowly block the neck, upper and lower neck, and we started with headache. The changing of the position, this very bad. The most dangerous situation is the retro position with vertical dimension is creating hyperactivity. And this hyperactivity going down slow. And we do a craniofacial diagnosis. Mandibular posture, daddy, also we study the body. The jaw position is centric. But said in our school, we have a neuromuscular postural vertical dimension and anatomical vertical dimension. Very short time to explain that now. We have two vertical dimensions. They have to be in coincidence to do not affect the muscle change. Obviously, jaw position, back jaw position, bad jaw position, teeth, muscles, etc. We studied the occlusion, obviously. When we found, we studied as a dentist, we studied the occlusion, the postural plane, we studied the movement, the guides, all. But the first thing I said before studying that, we have to put in balance the whole body. And then, when it's in balance, we have to have a good local diagnosis. If it's not, we lose the point. If we look only we have to first. And that's why in our protocol, we say first deprogram in balance with the book. Study the occlusion. We study buccinators, lip, chin, stone, breathing. All this have to be local diagnosis, and we do a postural diagnosis. We study the whole posture and the oculomotor system, the foot support, the muscle change, etc., etc., etc. The body, if the neck is functional, if we have a good function in the eyes, if we study the foot support, the foot support measure posturometry and stabilometry, we can measure the clinical. I was studying with the Dr. Bernard, not in Seattle. He said to me a very important phrase. They said, the clinical opinion can be true or false, but it's just an opinion to spot the posture, to transform our opinion in science. This posturometer is a very important device to study. If we are in balance, the whole body is based in different analysis of the very difficult to explain posturometry now, but we study the Kapanji concept, we study the body weight distribution in the floor, in each foot, and we have different situations that we can study, analyze. We call that clinical posturometry. And look at that. This is important research I did in 1999 because I was curious. And I want to see what happened with the pre-contacts in our teeth. Change the jaw position, obviously. If I have a pre-contact, the jaw position is changed. And I want to observe, measuring with the posturometer, what happened. 8% of the patient, we create pre-contact with the acrylic, with composite in each tooth, and we measure what happened. We create pre-contacts in the anterior guide, in the occlusal plane, and we observe what happened. And any time we measure with the posturometer, any pre-contact in the anterior guide, canine and incisors, making loose in the first foot metatarsus. The medial plane is making loose the weight homolateral in the fifth metatarsus. And in pre-contacts in the curve of SP or posterior guide is creating loose charge overload in the calcaneus. Like this. The first area, occlusal plane, curve of SP. Study that, we said how we treat it, the patient. Occlusion is very important. We said occlusion is the last. the professor say implant is the last. I agree totally. Nothing better than the teeth, nothing better than the normal teeth. Nothing at all. Yeah? But always occlusion. Occlusion is the last I have to treat, not the first, because we have a lot of influences of the muscles that can affect our central relationship. And that's what we create some annulate the occlusion for a short time, is calling that deprogramming. When we obtain the deprogrammation of the jaw, we can have a good body rehabilitation. And then we reprogram the jaw, any technique. We call that the reprogramming, progressive reprogramming of the jaw. That means founding the central relationship and the vertical dimension, the neuromuscular vertical dimension. And in that position, we study what to do with the teeth. That is our problem. The B.E.D device is simple plastic in rehabilitation. That's why I call it B.E.D, to make the difference between a biplane. It's body equilibrium device. It's a device for the equilibrium of the body. It's a very different concept to make the rib. After that, we do the occlusion. We make the registration. Always we use articulators, all the tools in dentistry. We change the concept, how to work. I don't invent nothing in dentistry. I teach my technique in orthopedic, if you like, but in dentistry is good. But when we have to do orthodontics, we have to do prosthetic, you have to do something to make a good analysis of the occlusion with all techniques. Today 3D is helping us. We use a lot of technologies, but we change the concept on diagnosis. Don't see first the teeth. And then, I don't want to be more stressful. We have a patient who have, look at that, a real short leg, who have a side mandibular deviation, and we see what happened. Look at that. This is real. Inside working bad, and it's making on the top chronically, not now, chronically. And then this short leg, lateral deviation, vertical dimension loose, guides are nothing. We have nothing with occlusion. And when we do the misfocus of lateral deviation of the mouth, the loose of the overload, the body center is moving, have torsion of the body, then we can measure a lot of things. We are overload with the B.E.D device and a very short insole to correct the short leg. That was the theory. Just to show you how well can influence normalizing and before and after. How the mouse can affect the posture. That I want to show you that. How the job position also patient with vertical dimension loss. We do deprogramming, reprogramming, and then the rehabilitation. We found the vertical dimension, we measure the vertical dimension. Look at 14 kilos of overload this patient in the body. Look at how can affect the body and the body center. We change it with the restoration. That's why we measure if our vertical dimension is not affecting the body. Another patient with also the vertical dimension loss bruxism is a long time bruxisms, and then the kilos. This is our courses in our school. We have an international school, and this is just to show you the connection between craniofacial system and the rest of the world. And I believe the whole medical sciences need to understand that. That's why in our school we teach for all of them. It's more complex than this. In this short time, I cannot explain the whole protocol. We study alimentation, biochemistry, etc., etc. The cycle is a lot of things. But in the have to work together with other specialties, not just alone. We need the collaboration, and to work together, we have to speak the same language in diagnosis and therapy. That is NPR. Speak the same language to work together. The holistic and interdisciplinary protocol. Medical sciences in the last times is in their point of view. And I believe that the point of view is interdisciplinary diagnosis and holistic diagnosis to work together. If we work together, it's good for us. And it's good for our patients. Enjoy the presentation, and let me know you enjoy the presentation. It's very complex, the presentation to explain in 1 hour, but I hope I be clear to all of this, okay? If you have any question, I am here just to answer the question, all right?
Subject, which is very important, craniofacial dysfunction, which is very important for the health and the well-being of the people. And the treatment, and easier the treatment, better is the treatment, instead of waiting the last minute and to make the treatment. And this is an issue which is in relation with the treatment of this kind of dysfunctions. And I'm sure that whoever is watching appreciates all the small details that you give. You may based on your 50 years of experience. I have almost as much experience anyway, so I appreciate what you went through during all these years, all these periods of dentistry, improvements of dentistry. Thank you.
Hey, very happy to be here with all of you. Thank you so much.
We appreciate it. Thanks. So, is Dr. Fabio Savastano, and Fabio Savastano is highly experienced medical doctor and orthodontist with extensive teaching, and he got his MD degree from the University of Naples and his specialty degree in orthodontics from the University of Padua. Since 1988, he has focused on applying the principles of neuromuscular dentistry to orthodontics based on a unique diagnostic and treatment protocol. His contributions to the field
Hemos terminado la presentación. Ojalá les haya gustado. I hope you enjoyed the presentation, and you can see in the YouTube channel. Thank you so much. I'll see you in the next presentation.
Director of the M.A. program in neuromuscular orthodontics